am Jeremy Pettus. Changed my shirt. You guys say hi real quick.
I'm Schafer, Boeder.
Steve Edelman.
Tricia Santos.
And we're all endocrinologists at the University of California, San Diego. So this is the live Q&A section part of it. First of all, thank you everybody for joining. I hope you've been enjoying the day. And I hope you can also tell all the time and energy and work that we put into this, doing something a little bit different. And the reason we wanted to do this in a different way is that we actually have a ton of content now on our website, tcoid.org. Go to our video vault. There's a lecture on anything that you would want to hear about, pumps, sensors, how to control your blood sugars, exercise, whatever. And since we have all that content now, we thought we should do something different, take people around, less slides, more kind of real world, seeing my house. That was fun, where I work. Beating Steve in the pizza challenge was awesome. Before I forget, if you have the means, please click on one of the links to donate, because we are really dependent on your contributions to keep these things going. And, all of your funds go to create these types of programs, and we just can't do it without you. And as you know, we make this available for free for everybody in the world. And that really is our mission. And in order to keep doing that, we really need your help. So you can say something.
I'm just going to add something. No, I didn't want to interrupt you. Just remind you that the VFairs platform that you're seeing today is going to be open for 30 days. So you can go in, watch the lectures, refer friends that are interested in type 1 or have type 1. And we also have the on-demand lectures, which covers topics we didn't have time to cover today. And those on-demand lectures are also in the video vault. And everything you see today after 30 days will be transitioned into the video vault. Jeremy, thank you for being the chauffeur today. Your arms have to be sore. Have to be.
A couple more things. So please put your questions in the chat box. Anything that you want us to cover, Tricia is going to be kind of combing through those and feeding us those questions. Please turn on your camera if you want. We can see you guys right now. We can see all the boxes. Wave, say hi. That's really super cool. Obviously, we can't be in person, but it's actually really nice to see people's faces because, to be honest, we work our butts off to do these virtual programs. And then at the end of the day, they're over. And there's like 4 of us in the office, and we're like, well, did people like it? I don't know. So it's actually nice to see people and see you guys smiling. So
hey, really nice pajama bottoms.
Yeah, we love
awesome.
We only have 2 naked people, which is pretty good.
Where?
All right, so Tricia, do you want to get us started?
Yeah.
Or
Okay, happy to be here, you guys. It's so fun to see your faces on here because there's so many benefits to the online program, but the one thing I really miss is being in person, especially for the one conference where it was really this kind of weekend where we were all together. So it's so nice to see everyone. The first question I see here in the chat box says, how do I find a mental health professional to help with my diabetes ride? And this question just cannot be underscored enough, I think. And Bill Polonsky, who's our TCOID kind of mental health professional, diabetes psychologist, does a lot of work here. Head to that video vault that Jeremy was talking about because he has tons of content there. He's been here today. But what other suggestions do you guys have for your patients?
Well, I can just add something really quick. Bill and his colleague Susan Guzman, they're really touchy-feely folks. And you saw Bill fix our flat today. They have a nice website called the BDI, Behavioral Diabetes Institute. You can email Bill, you can email Susan, you can ask questions, and they will help you find a resource depending on what area of the country you're in. There's just not that many people like Bill. There are, but there's just not that many. So it's a great question, and we do need help from time to time.
Yeah, I would say, if you don't have a Bill, which most people don't, is get a good diabetes educator, a good provider. If you aren't comfortable with the person you're seeing, for God's sake, switch. We never take that personally.
I do.
Yeah, well, people always leave Steve and come to me. So get a good provider, get a good team, and then, just a support network. It doesn't have to be a trained professional, but somebody that you can kind of talk to about your diabetes, your struggles. You can see a kind of a regular psychologist and talk about some of these issues also. So in the absence of Bill, you just got to put your team together.
Totally agree. Okay, let's look at this next question, which is about a hot topic right now, the COVID vaccine. So the question here is about whether patients with type 1 diabetes should be getting a booster shot. What do you guys think about that? And maybe comment also on just getting the vaccine in general for those who may not have gotten it yet.
Schafer,
Yeah,
come on.
you guys, talked about this a little bit at the start of today when you're driving, and I think you did a good job. Well, and what Jeremy kind of mentioned, which is true, is that we know that people with diabetes, and that includes type 1 diabetes, if you actually get if you get infected with COVID-19, you're at higher risk for not doing well, so for having bad outcomes. And that's what we want to avoid, obviously, is preventing, ending up in the hospital or worse. And so obviously we, fully support getting the vaccine because that's going to reduce a risk of ending up in the hospital. That's the whole point of it, and getting sick from COVID. The booster is interesting because, there are specific guidelines that are put out, now that certain people that they're recommending the booster for. And to me, those recommendations make a lot of sense. So it's people that are over 65, people that are at especially high risk. And, I haven't seen that they've mentioned specific, underlying conditions like diabetes. I haven't seen that yet. But
autoimmune conditions.
But autoimmune conditions is on there, and type 1 diabetes is technically an autoimmune condition. And so I think if you're interested in getting it, I think there's a good argument for it. And I think the real life answer is that it's going to help protect people.
Yeah.
So if you have the opportunity to get the booster and you're due for one, get it. No, I already got the booster. I'm not over 65, but I work in healthcare, which is another reason to get it. So I got it as soon as I can. Because I'm trying to protect myself and my family and my patients. So we believe in it. But
he's dangerous. He runs an outpatient clinic for sexually transmitted diseases. So you need a coverage.
Well, I would say the bottom line is get vaccinated and get your booster when you're eligible about 8 months after your first kind of set. We've all gotten our booster now and we all did fine.
Yeah, Jeremy, since we took that little bus ride, the FDA came out with, they said 6 months after. And they also said that if you got the Moderna, you should get half the dose of your first 2 shots. And, so the guidelines are changing, and that's good because they're looking at the data as it comes in. We're big believers of getting vaccinated. And you know what the main reason why we are? We see what happens in our hospital as patients with diabetes. It's really sad.
Yeah, I don't want to be scary or whatever, but Tricia and I, in particular, work in the hospital, and we see people who are just really sick. And really from the start of this, it's really, kind of set my mindset for how I think about it. And anything that we can do to stay safe and stay out of the hospital is a good thing. So support it.
What do you got next?
Okay, so next up, there's a question about getting through those lows that just don't seem to resolve after you kind of keep treating, and you're still persistently low. But maybe I'll broaden that out a little bit and have you all comment on the new glucagon preparations and kind of the differences between them.
First, I got to tell this story about...
That's exactly what I was thinking of.
I got another low that just happened this last week, and I don't even know what happened. It's like the oddest thing that's happened to me in the history of having diabetes. So I was driving, and I started going low. I had actually taken some glucose tabs while I was driving, and I happened to be by McDonald's. So I went in McDonald's. I got like a Big Mac and some chicken nuggets and ate them, and I was like, you know what, screw it. Like, I'm just going to enjoy this food because I'm low. I ate all that. I went low again. I hadn't bolused any insulin. I got back in my car, went to the drive-thru at the same McDonald's, ordered a large fry and another hamburger. And then when I pulled up to the thing to pay, because there's like the pay thing and then like where you actually get your food, I was like, hey, can you add on a large chocolate shake? And they're like, okay. So I went and got all that and ate it all, and I still got low. And I really just don't know what happened. This is something that totally threw me for a curveball. So, one solution is eat your face off at McDonald's, which is not a good solution. But you're right. For glucagon, there's so much going on in glucagon. We've talked about times that we've had to use it. The old standby is this one that you have to pre-mix. It's a real pain in the butt. There's now much better glucagon options. There's the Gvoke pen, which is a pre-mix kind of like EpiPen that you don't have to mix it at all. You just push it. You push a button. You don't see the needle. Super easy to give. There is an intranasal version called Baqsimi that you can just squirt in your nose. There's no injections, anything like that. There's also the Zealand product. Zegalog. That's very much like the Gvoke pen. So bottom line is there's new formulations of glucagon. Ask your provider about it. Make sure you have a prescription. Make sure somebody knows where it is
and how to use it.
Yeah, and make sure it's not expired. And Jeremy, there's no push button on the top, but I just want to emphasize that because it's so easy. you push down this little spring, it gives it to you automatically.
Just pop it right in.
Yeah, and my 30-second or less story was I overdosed myself. I stacked my dose and I could not eat anymore. And I thought I was just going to go so low I was going to pass out. And sure enough, I just got it out. I gave it to myself and I was just amazed. It was like exit stage U-turn.
Yeah.
And it came right back up and it did not rebound that high. So I try to keep one. I got one in the office. I got one in my suitcase. I got one in my car.
Yeah, I have that, and I have like a preloaded McDonald's chocolate shake in a pen now that I inject every once in a
And
while.
by the way, later I'll tell you what to eat when you get low.
Yeah, but that was weird. But anyways, the last thing I'll say about glucagon is people always say when they see me as come in to see me, I don't need it. I've never used it. Well, you don't need it until you need it. Yeah. And I've had to use it. You've had to use it. Just goes to show it can happen anyway.
There's always a first time.
Yeah.
Yeah, so make sure and ask your doctors if you don't have a prescription, and those of you on pumps, ask for a prescription for basal insulin in case something happens with your pumps. Those are kind of like the two safety net things that you really need to have no matter what. Okay, so I'm seeing some questions here on other medications besides insulin for people with type 1 diabetes. There's a question here about metformin. There's a question about Ozempic. I know we have on-demand and video vault sessions on this if you want some more detail, but can you give us kind of your quick thoughts on these medications and whether or not they should be for people with type 1?
Yeah.
That's a good question. It's always an important discussion because, none of those medications, other than insulin, pramlintide is the only medication that's approved for use in type 1 diabetes. But these other medications that are what we call off-label can be used for type 1 diabetes in the right setting. But, it really requires you, understanding why you want to use those medications. It requires you and your provider having a discussion about that.
Yeah.
What are you going to get out of it and what are the risks and the benefits?
I'll just add that my particular situation, I do have chronic kidney disease, kind of, 50% function down. I talked to my nephrologist and she suggested I go on an SGLT2 inhibitor, in this case Farxiga, because it's been shown to reduce the progression of chronic kidney disease. So, I got educated on it, looking out for euglycemic decay. So there are particular uses now that people are using these medications.
And I think you gave a talk on this, right? On like another drug that's
Yes.
in the video vault. So again, go to the video vault, type 1 diabetes, and Steve gave a whole talk about this. But real quick, metformin we don't use for people with type 1 diabetes in general. Sometimes we'll use these GLP-1s and SGLT2s in just kind of regular people with type 1 diabetes. If you look at everybody, the reason we use these is they help your blood sugars a little bit. They can help you lose weight, but they do have side effects, and you need to kind of talk that through with your provider.
And now that we have these hybrid closed loop systems that we'll talk about, we found that really helps round off the highs and the lows just as good as any of these other medications.
All right, what else we got?
Yeah, and just on that note, for if you have type 1 diabetes and you are overweight or obese, you may qualify for these GLP-1 medications because some of them are approved for weight loss in people without diabetes.
Yeah.
How heavy?
So it depends on your BMI and your other kind of medical problems that you have, but if your BMI is over 30, you certainly probably would qualify.
That's a really good point because I have been able to get GLP-1s for type 1s when it's for obesity. Yeah.
Yeah. Okay. There's some questions on here about insulin. I'm curious if you guys can comment on some of the newer insulins that are available. We have newer basal insulins. I keep saying newer. They're not even that new anymore, but we have certainly newer rapid acting insulins. Can you guys comment on those?
Well, I'll just start off with the basals. When Toujeo and Tricia came out, and their data clearly shows it's flat, they're flatter, they're longer, much better than Lantus or Levemir. And, all the marketing is going for type 1s and type 2s, but I feel there's no other better group of people where you really see these benefits than type 1.
Explain the difference. What are these newer, what do they do?
Yeah. Well, they, instead of Lantus having a little bit of a peak and then it loses activity before 24 hours, we call it pharmacokinetics, pharmacodynamics, big fancy words so you're impressed. But when you inject it and you follow the levels over time, they're flat, kind of like the basal rate of an insulin pump. So people have less unexpected blood sugars. And I have proactively converted all my patients on Lantus or Levemir or MPH like Jeremy was on over to JO or Tracebo.
Yeah. So the bottom line is, if you're on shots, your basal insulin should be one of these newer insulins, Toujeo or Tracebo. They are more consistent, less hypoglycemia. They're just better basals.
I was just going to say, sorry, I interrupted. That really important point. When you start these, because they're so flat and they last so long, it does take 3 or 4 days to reach equilibration. So don't get frustrated when you switch over and your blood sugars are elevated. You may need to do more correction.
Yeah.
Sorry.
No, but then rapid acting insulins, we would be remiss if we didn't spend some time talking about Afrezza. This is something that comes up in all of our different talks. We've done probably multiple talks on it now in our video vault. This is an inhaled insulin, if you haven't heard about it, by a company called Mankind. They have a booth here. It's nice because it's inhaled, but honestly, as type 1s, we don't really care about injections or not. But what's really cool about it is how fast it works. Nothing will bring your blood sugar down faster than Afrezza. And again, I could do a whole hour talking about it, but please check it out on the video vault. Go to the booth. It's just fantastic for bringing down those stubborn highs when you're 250 and it seems like it takes all day to come back down into range. Something that can bring you down quickly. Something that you could take to kind of combat higher carb meals. Did we both use it in the pizza challenge?
You did.
I did to kind of I literally went to 179 and I thought I was going to lose. I was so upset. And I took Afrezza and I was like, meh.
There's no way that would happen if you gave, a shot or even a
Right.
bolus or your pump. You'd be waiting a half an hour for it just to start.
Well, you know what we did today was watching the video. We got so hungry, we ordered pizza in, and I took 2 8s because I
8
started.
units of Afrezza.
Yeah, 2 8 units of Afrezza. Sorry, just because I knew I needed something because I started off at like 165. It's just a great thing to have around. There's many different ways you can use it. Just depends on your own individual needs.
And then people will ask, what's the deal with Fiasp and Lumjev? And that is a mouthful, Fiasp and Lumjev. So we've had Humalog and Novolog forever, right? And now each of them has kind of the next iteration of that product. So Humalog, the newest version, is called now Lumjev. And Novolog, they've added a couple things to make it Fiasp. And it's the same exact insulin, but they've added a couple ingredients basically to the formulation to make it get absorbed slightly faster. Both of these are now approved for your pump, or it can be used as shots. It's something worth trying. If you do switch over from Humalog or Novolog to one of these, don't change anything. Your carb ratio stays the same. You still have to pre-bolus, and you might notice that it takes a little edge off your highs. So that's all I kind of have to say about that.
I have a follow-up question for you on this, Jeremy, or maybe Steve, you can answer too. What about using the Lumjev or Fiasp in an insulin pump? And what about using Afrezza for patients who are on a hybrid closed loop, like the Control IQ or looping?
Yeah. So you can use both of those in the pump now. It's just kind of recently approved for Lumjev. And then you and I...
I was telling him he's able to jump in too.
Okay.
He's the youngin' here, so.
But Steve and I we are on a hybrid closed loop system, and we both use Afrezza with it. Yep. And people will ask, well, does that mess up the algorithm? And long story short, I think no. That, we'll use it at the beginning of a meal or to correct, because these algorithms are trying to correct your blood sugars, but they're not aggressive enough. So, I find that you can still use Afrezza or, a correction to help it out, basically. It works really well.
Yeah, these algorithms, they work based on the prediction of your blood sugar. So if they all of a sudden see your blood sugar start dropping, their algorithm changes. And if the algorithm doesn't work, get a new algorithm.
All right, let's move on. I'm going to switch topics here a little bit. There was a question that somebody said, I heard that A1C is not that accurate in patients who are over 65 years old. So one thing I love about our TCOID members is they are so educated. Mm-hmm. They do such a good job coming to this conference. And somebody already answered this question in the chat box. I want to give a shout out to Eric H., who says, A1C is not really the key that it used to be. Time and range is so much better. So I want to throw this question to Schafer. Can you talk to us about A1C and whether it's accurate, and what can we do about that?
Well, yeah, A1C is a funny thing because we put so much weight on it historically, and it's always kind of been the go-to. And a lot of patients and providers it's still kind of the main number, that people follow, but it has so many problems. And so really, time and range is something that we're turning to more and more, and really understanding that that's the most important number. Of course, that's if you're wearing a CGM. If you're not wearing a CGM, go get one. But the time and range gives you so much more information, and the A1C can be wrong for a lot of different reasons. So people who have kidney disease, people who have anemia, all sorts of different things will change the A1C. And because of that, a lot of times we'll download a CGM, data, and we'll get an average blood glucose from the CGM, and then we'll look at the person's A1C from the lab, and they don't match up, and so that's confusing, and for us and for patients. And ultimately, the CGM data is what I go off of, because that's going to be the true, measure of average glucose, and it's going to be more accurate. There's just not as many things that'll mess it up.
I'm anxious to jump in there
Get in there.
That's been my thing lately, is that, there's a video on our website called Why the A1C Sucks and Why Time and Range is so much better. It's all explained there. But the bottom line is, that question and answers were awesome. There are about 30 things that can make the laboratory method inaccurate. Aging is one of them. Whether you could have chronic kidney disease, you could be anemic, you could be pregnant, can be African American, sickle cell trait, a ton. And Earl Hirsch made this popular. He's a type 1 endo in Seattle, and it could really lead to the wrong suggestion in clinic. None of those factors affect your blood sugar. I just want to remind people that when you do look at that GMI, Jeremy and I hate that word, glucose management indicator, that's the true A1C, but you got to do it over.
Well, tell them what that's what's on the download of a CGM. It'll say GMI, because it's not really your A1C, it's a predicted A1C. And that is what we like more than the real A1C.
But it's formatted the same way. So the GMI will say like 7.1%. Right. It's meant to be like a predicted A1C, but it really represents your average blood sugar.
Yeah, so don't compare the 30-day GMI to your A1C, because A1C is for a longer period of time. Do your 90-day average glucose GMI, and that is the true A1C to me. And I think the laboratory method should be called the estimated A1C.
And while we're on this topic real quick, and I think we should get to the next one, because people freak out when the A1Cs don't match, but they also don't like when their CGM doesn't match their blood sugar meter. And they'll ask me all the time, what do I do if it's off? And honestly, my advice is stop testing, because there's a lot of things that can make the blood sugar meter inaccurate, and people think that that's the right answer. But use your CGM. These things are very accurate. If something feels off, you should always confirm it with a finger stick. But don't get too hung up on, gosh, it's off by 10, it's off by 20. Like, what do I believe? The CGMs are very accurate in general and should be trusted.
I hope all your engineers out there are listening.
While we're on the topic of CGMs, what is kind of the up and coming news about CGMs? What's out there? We know that there's kind of new versions that we expect to come out soon. What are we looking for?
Yeah, I can start off. Leslie covered that really well when she went and visited Jeremy's lab. But we have the Dexcom G6 now changing to the G7. We don't know when, but it should be soon. A lot of it nice advances. And I love the fact that the transmitter is built into the sensor. You don't have two things. And we don't even know how long it's going to last. And that 2 hour calibration time we have to wait. I love it. And Leslie says it's the longest 2 hours of her life. Mm-hmm. And we're so spoiled these days. So Dexcom, really is the leader in terms of communicating with pumps too. And you might comment on that later on. The Eversense, they're in the health fair. It's Essentia. It's already approved for 90 days, a little sensor that goes under the skin in a very short office procedure. And then you use the data goes through the skin to a little transmitter to your cell phone. And it's 24/7. They got really nice software. They're working on what they call interoperability with pumps. And they're waiting for the FDA approval for 180 day. I think that's going to be really nice. And it's already approved for 180 day in Europe, and they're working for the 365. Wow. So that'll be super nice. And the Freestyle Libre now is the Libre 2, which has the alerts and alarms, a huge advance. And then there's the Libre 3, which I do believe is going to be more of a continuous glucose monitor.
Yeah, for me, CGMs have reached the threshold where they're really good, and we don't have to calibrate anymore. They're really accurate. And I feel like now we're into this phase where everything is just kind of gravy on top, making it, we're not talking about accuracy so much anymore. We're talking about making it easier to wear, integration with systems, things like that. I think we've gotten across that hurdle. of having accurate devices that can dose insulin, and that's so important.
It's a personal choice too, which one you pick.
Yeah, I mean, it's a personal choice, and depending on what your insurance covers, and what you can afford. I mean, cost is an issue for sure. They're not cheap. But I think, fighting for coverage and making sure that you have a CGM is super important.
Yeah, I'm glad you mentioned that, because we're going to talk about a lot of products that you may not have access to normally. If you go to our website and go to our blog, we have a resource center. If you have any questions at all, we will get back to you. Lynn Schafer in our office, she hunts us down. We answer every question, even finding a clinical psychologist in Kansas City.
Yeah.
We can help you do that.
And you actually did a talk, I think it's on the video vault, on type 1 diabetes and the cheap, right?
Yeah.
We want to be sympathetic to that. A lot of these things are still expensive and too expensive, frankly. So can you get, how can you do this if you're on a limited budget?
Yeah, it's a really good lecture, and we wanted to make it available to people who don't have access to all the latest and greatest. And I can just tell you that you put a little effort into it, you can do just as well as anybody else.
I gotta say, I love seeing like a couple of you guys with other people on the camera. That's just awesome. You got your family there with you or whatever. It's so important to have this community. And so yeah, we see you guys waving. That's awesome. Pretty soon we're gonna make you guys stand up and do some jumping jacks, but that's coming a little bit.
That is, we have you on kind of a pretty big monitor, so we see a lot of you folks. We love it.
Yeah, it's awesome.
And it keeps switching to the next panel.
While we're on the topic of CGMs, there's a question here about how to get your CGM data or information to your primary care physician or to other physicians. So in the endocrinology world, we have the ability to kind of download and get all this fancy information. But what if you want to share your information with someone else? What do you do?
I'll just say the easiest method. Sorry.
No, please.
The easiest method is you download it yourself.
Yeah.
And you fax it, you mail it, you email it.
Print it out, take it in with you.
Print it out, take it in with you. They're not going to look at the data ahead of time. They're just too busy. Not that they don't care. They're just crazy busy. And, and I'd say the most important thing is for you to look at it yourself. Schafer and I gave a lecture on Think Like an Endo.
Yeah.
And we just take you through the CGM download. And it's not that hard. And I bet you that you could be way better or more familiar with that than primary care doctors.
Yeah, I mean, some primary care doctors are super familiar with this, and you can probably take your CGM into your clinic visit and they download it, but maybe not. And even in the endocrine clinic, sometimes we struggle with this because there's so many different types of technologies and things. So if you have, your CGM, or same with your insulin pump, they each have their own websites and programs that you, as the user, can go and download your own data. And so, do that to take into your appointment, but also do it for yourself, because that downloaded report that has all of this information about you. And so that is available for you to use and for you to look at.
I think that really is core to the message of TCOID, is empowering people to take control of your diabetes. And it really is unlike most other illnesses where you go to the doctor and you expect them to kind of fix you. And here, they're, whether it's appropriate or not, there's an onus on the patient to know their information, come up with ideas of what you think is wrong or right. I mean, I can tell you that appointments are so much better when somebody comes in and says, hey, I've noticed that I'm high after dinner or whatever, or I want to work on this specific thing, rather than, download my stuff and you figure it out. Yeah. I think it really takes this this teamwork approach, and that's how you get the most out of it. And if you go into your doctor and say, hey, I heard about Afrezza or whatever, and I want to try it, that's good. We like that. That's not you overstepping. That's you taking control of your diabetes, which is the whole point of all of this.
Jeremy, well said. Well said. I really appreciate that. I just want to add that there were a lot of people in the chat box when we were talking about one of the shows, and people are frustrated because their doctors won't give them Afrezza. That's a very common theme.
And Sorry. When you hear that, I don't want to give you X, I don't want to give you Y. It's not because they're bad, it's because they're not familiar with whatever it is. And doctors or providers, they don't like to change, and they don't like to feel like they don't know something.
And to be honest, the diabetes world is moving faster than a lot of physicians can keep up with, and other providers can keep up with. And so, yes, it's hard for us to keep up, and we only do diabetes, so it's not that they're bad doctors either. It's just
some of them. Just do a gesture now I'm not going to move this other hand, but it might make you feel good. Switch doctors if they just are not amenable.
What do you guys think? Maybe thumbs up if you like your provider, thumbs down.
There are some providers.
I see some thumbs ups.
There are some providers whom you may think about switching. I mean, that's the other thing. Occasionally, if someone's stuck and they're not willing to try a new insulin, or they're not willing to prescribe a CGM, or they're not going to take the time and effort to do that, when that's like the appropriate therapy, like.
And to be fair, though, sometimes there are reasons why you shouldn't be on something.
Yeah.
So at least they could tell you, hey, I don't want you to be on this because X, Y, and Z, or it's been shown, whatever. But, have that conversation.
Yeah, and they have big egos, so you just be really nice.
Be nice to them.
Yeah, and, thank you for listening to this suggestion for me, stuff like that.
All right, let's move on. So while we're on the topic of CGM, I see some questions in here talking about some of the hybrid closed loop systems. So maybe I know we have a lot online about this, but if you want to talk about the hybrid closed loop systems, the tandem control IQ, and then there's also a couple questions in here about when is Omnipod coming out with their system? Will Eversense be integrated into these systems?
Yeah, the Omnipod 5 has been coming for about 17 years now. So
the dash.
They keep saying any day now, and it will come out. But Steve and I are both on hybrid closed loop systems. I'm on the Tandem Control IQ. Steve uses the Omnipod and loves it, but they don't have a hybrid closed loop system yet. So he's looping, which again, we have information on the Video Vault on how to do that, which is kind of a, bridge to potentially the Omnipod 5. I have heard, however, that initially the Omnipod 5 is only going to be on Android. And so you have an iPhone and it's still looping. So anyways, these systems are fantastic. The Control IQ has really been a game changer for me. Because I've mentioned a million times, it's mostly the overnight control. I don't get low as much at night. I wake up generally with a good blood sugar, kind of in range, regardless of what I was when I went to bed. So waking up with a good blood sugar, you just know that day is going to be better. And I always tell people the reason I wake up with a good blood sugar is not because I'm smart or I'm a physician. It's because I have this system that's doing something every 5 minutes overnight that I can't do. And I love waking up and looking back at the night before of how much insulin I've been getting. And some nights it's giving me a whole bunch more insulin, like if I've had pizza or something. Sometimes it's giving me a whole lot less if I maybe exercise that day.
We're shutting off.
Yeah. And it makes me realize that how could we ever hope to get good overnight control with just one basal, set every single day? Like, it requires constant vigilance and modification, something these systems can do. And they're only going to get better. We call them hybrid closed loops because it's not a fully closed loop, because you still have to bolus for meals, you still have to count carbs, all that kind of crap. And that's the next kind of, big hurdle that'll be coming in the next couple years, where we could truly, tell a system, hey, I'm eating, but maybe something just that simple. Instead of 17.5 grams of carbs that you got to weigh, and then you got to do advanced, calculus for the fat and protein. It's ridiculous, all the stuff that we have to do. So to have a system that can kind of start doing that for us is the next
You're not
step.
going to make fun of Jeremy's notepad?
Well, I was going to, but
I beat you to it.
Jeremy and I made this probably one of our best videos. Not the best technology before Eric, our videographer, was here, and our ultimate video person. It was called Type 1 Diabetes in 2026, and we did it like 4 years ago. Mm-hmm. And we lost
we did
our
in 2016, so it was like we were predicting 10 years ahead. Mm-hmm.
Yeah, the scene opens up. I'm at Starbucks working, and comes up and says hi. He tells me he's cutting hair, but he's not actually cutting hair. He's just cleaning up. He's cutting hair is the next step, because the university fired us. All of our patients were on closed loop systems. In answer to that one last question.
Well, the point there is that's the idea, right? That we get to a system where you wouldn't need your endocrinologist. I mean,
so true.
I think, but basically what it's going to be is that it's going to be picking between these systems like we always have, but the features are going to get better. 5 years ago, you were still picking between Omnipod and Tandem and Medtronic, but they didn't do anything. Now you're still picking between these systems, but they're starting to integrate, and that will be the way that it just kind of keeps going.
Yeah, I can just say a few words about what's on the system now.
Okay.
The Medtronic 670G came out years and years ago. It puts their sensor with their pump, and then came along the looping, and that's not FDA approved. It's got, I like it because I don't like using tubing, but the algorithm, we don't really know what goes into the algorithm, but it works well, and I'm happy with it. And then there's the Control IQ, which is really the Dexcom sensor with the Tandem T-Slim.
Mm-hmm.
It's an excellent system. And what we're waiting for is the Omnipod 5.
Which uses the Dexcom sensor.
Thank you. And then the answer to the question was the Eversense is right now figuring out their communication with a CGM device to come out with their hybrid closed loop, but not yet.
Do you think we'll ever get to a point where these pump systems, patients can choose which CGM they want to use with their hybrid closed loop?
We should get there. I mean, and I know, I think Dexcom has kind of led the way in that field with this interoperability.
Mm-hmm.
They're unlike iPhone and Android and these things that don't work together. I mean, they've kind of led the way, and there's been a lot of good feedback from that they want their CGM to be able to work with anybody. They're not saying only this one company or only, something that we make. And I think that's the way of the future, because if you have a pump but you want to use a different CGM, you should be able to make that choice. So I hope so, and certainly some companies are moving in that direction. And I know that's like you're talking about Eversense. I'm sure Eversense is also working for that, because they're going to want to be able to use their CGM with a different pump.
Yeah, but Jeremy, maybe you can say a few words about what Leslie touched on, was the Beta Bionics totally closed loop. You just put in the patient's weight. I know you and Schafer.
Yeah, we've done a lot of a big research study in this. It's called the iLet. People have probably heard about this. It's a little I, capital L-E-T. It's a play on kind of an iPhone, and also the islets, like in our pancreas. Anyways, in the system, it's a fully closed loop system, and it should be available commercially in the next year or two. And the real cool thing about it is that it works with a Dexcom. It's a typical kind of insulin pump, but when you eat, you can tell it that you're eating, and you just say, I'm eating a typical meal, smaller than normal or larger than normal. Very kind of qualitative, the way that everybody approaches food, again, rather than counting carbs. And in the studies of people that go on this, they tend to do pretty well. So again, this will be another option. And that's the way that the field is going, again, of, taking less onus off the patient to do all the work and more on the device. Because at the end of the day, what does everybody with type 1 diabetes want? We want better blood sugars, and we want to work less hard. And so that's the goal of any system, is to keep us healthy and have me not deal with all this crap. I mean, it's pretty simple.
Right. There's a question here on this topic asking, what about these hybrid closed loop systems versus using multiple daily injections? What do you guys think about that?
I mean, Jeremy kind of talked about that a little bit just in his experience, but as an endocrinologist, just seeing the effect of, on people that have switched over, obviously you got to make your own decision. I mean, I guess that's the first thing, to each their own. And some people just prefer to do injections, and I certainly support that. But the hybrid closed loop systems really have changed the game, I think. And, again, just better blood sugar, less hypoglycemia. They protect against lows in many cases and reduce the time below. And so there's a safety issue. And ultimately, having better blood sugars is going to decrease your risk for long-term complications. And that's what we kind of care about, this time and range of things. So these pumps, the hybrid closed loop systems, do that. And so you just can't get that precise control with injections. And like Jeremy said, you give a basal injection once a day, that's your basal. I mean, it's there all day long. You can't get more, you can't get less. And the pumps minute to minute are just adjusting and tweaking and getting your blood sugar better. So it's just impossible to do that with injections. But
what I used to, when I used to give lectures when these guys weren't even born yet, I'd say pumps versus multiple daily injections. It comes down to personal choice. And that was true. But I have to say that with these hybrid closed loop systems, I mean, patient after patient after patient in our clinics, they just do so well. And now you have a choice between 2 traditional pumps with tubing and 1 patch pump, and maybe another option with a second patch pump system coming out. So I would just say there's just no comparison. It's less work, it's safer. But on the other hand, if it's something that you really like, you're used to using, you're happy with it, more power to you.
Yeah, I would say I agree with all this, but nobody should ever tell you what you have to do. If you're doing injections, or maybe you're on basal insulin and Afrezza only, and your blood sugars are in range and you're not having a lot of hypos, great. We just tend to think that in general, if you took everybody with type 1 diabetes, people tend to do better on these systems. Doesn't mean everybody has to be on it. There's choices.
I totally agree with you, all of you guys. And, one of the things I always tell my patients too is you can give it a try and then if you're on injections, you can try it out. And if you hate it, don't use it, And I think the reason that we are suggesting it more now is just because of the safety and also just making your life easier.
Yeah.
But you're absolutely right, Jeremy. It's your decision. You guys should be the ones that get to decide what to do. What about when we're on this topic of multiple daily injections? What about InPen?
Yeah, I was just gonna say,
does that help people do better?
Leslie talked about the InPen. She mentioned that too in her talk. And it's kind of a, if you're interested in technology and having some of this information on your phone and having a bolus calculator and all that, but you don't want to be connected to a pump and you prefer the injections, I think the InPen is a cool option for sure. And the InPen, the smart pen technology, you get an app on your phone that tracks your insulin doses, and so then how much insulin's on board. You can you can put your blood sugar in there, you can count your carbs and put it in there, and it'll just kind of spit out the dose for you. So it takes a lot of the math out of it, at least. I mean, you still got to bolus, you still got to count your carbs, and you got to check your blood sugar, look at your CGM and put that in, but you don't have to do the math. And so even that I think is important. And I don't have type 1, but I think it's a common experience, since this is a 24/7 thing. Did you give that injection just before you ate? And sometimes, people have, you'll give the second injection or you just forget one completely. And the nice thing about the InPen is if you forgot or you're not sure how much you gave, it's right there. You can go back and look at the app. So it's nice to kind of have that backup support.
That is just that last thing is a big thing. I mean, how many, like when I did injections, how many times would I do an injection? Because you've done tens of thousands of them. I would take 8 units for food, and then I would look at my pen and be like, God, did I just do that? And then you have no good option. You either dose again, and you maybe either double dosed or you don't dose, and then maybe you got no insulin. So it's a crapshoot.
Yeah, I just saw an advertisement on television on the InPen, and it could suck in either the Medtronic sensor data. Medtronic owns the InPen now, or the Dexcom. So that's nice too. And it does look like a vape thing though, because it's more metal and
It's a
stuff.
little electronic pen.
It does a little bit.
But you guys should know that Schafer does not have diabetes. Jeremy and I obviously have diabetes, and Tricia has an honorary diabetes degree. And there's only 3 people in the world that have one. The first one was Bill Polonsky. It's basically, really knowing what it's like to have diabetes, but not having diabetes yourself.
So again, Schafer does not have that.
I'm the one here.
What I say?
I don't.
Yeah.
He's working on it.
I don't know
Maybe
what I'm
next year.
talking about.
But you know what? He's getting close to the award.
These are not given out at some interval. These you have to earn them.
Yeah.
I mean, I'm doing laundry for these guys. I don't know. I don't know whether.
All right, there's a few questions kind of streaming through about complications. There was a question about gastroparesis. There was a question about kidney disease. There was a comment saying that retinopathy is inevitable after a certain number of years with diabetes. So I'd like you to comment on, the risk of complications and what can we do? Because I think, this is the other thing that kind of weighs heavily on people's minds.
You go first, Schafer.
Well, so complications is a scary topic, and it's also a big topic. And so, when we talk about complications, like amongst, providers, and if we're giving a lecture to, primary care doctors or whoever it may be, we a lot of times break them down into 2 categories. So there's what we call the microvascular complications, where that means small blood vessels. And that's really like the eye damage and the kidney damage and the neuropathy nerve damage. And so there's that group of important complications. And then there's what we call the macrovascular, which is the big sort of blood vessel complications. And that's things like heart disease and stroke. So both very, very important, but different, because they kind of respond differently in terms of how we can prevent them. And the microvascular, so again, that's retinopathy, the kidney disease, nerve damage, those are extremely associated with your blood glucose control. So having, increased time in range for, over time, over years, is going to reduce your risk of those complications. And really having blood sugars that are, as close to normal without having lows over time, that your risk of developing those complications can go as close to zero as someone without diabetes. So those are those small vessel complications that are very serious if you, have kidney problems or eye problems, but those can be prevented with good blood sugar control. And if you've developed some of those complications, as many people have after many years and decades with diabetes, any improvement in your blood sugar can reduce the risk of those things getting worse. So it's never saying, hey, I've already got some retinopathy, screw it, but it's preventing further problems. And then the other side of those the heart disease and things like that come with diabetes. Blood sugar control is still really important, but there's all these other factors that are involved in that. The things that affect everybody else, like who don't have diabetes, your weight and your blood pressure are super important. Your cholesterol.
People eat lots of eggs and stuff.
Yeah, if you eat too many eggs. So those are the kind of two categories, but they do share the need to kind of maintain that good blood sugar control, and that will reduce your risk for both types of complications.
Yeah, let me just say, how many people were told when they were diagnosed that they just lost 10 to 15 years of their life? I definitely was, and I was 15 when I was diagnosed, and so were you, and I always think that's a messed up thing to tell somebody, but that's just not true anymore. So I think we all believe that, it's just a matter of time before I go blind or my eyes are messed up or kidneys. It's just not true. If you control your blood sugars, there's now evidence showing that people with type 1 diabetes live just as long, if not longer, than people without diabetes. So it really is a whole new world. And when you think about that, it kind of makes sense, because we're seeing, doctors maybe more regularly. We're on top of our blood pressure, our cholesterol. We're thinking about food and our weight and all these things. So a lot of times when I see people with type 1 diabetes and, they're 60, 70 years old, they don't have any complications, I literally tell them, you're going to die. You're going to get hit by a bus. Something else is going to happen to you that has nothing to do with diabetes.
You should really look forward to that.
Yeah.
And he's going to be driving the bus.
And I tell people, it might be me. I tell people that should be all of our goals, right? And most of you out there, something else will end up killing you, and not to be too grim about it, but that's actually pretty exciting. That you're going to make it to the end without, diabetes really having mattered. You got to work your butt off to control it. And if you have complications, I know, Steve, you do, and you have probably a lot to say about this. It's not fun, but they can be managed. And, it's about your mental state in it. I don't know what you're going to say.
Yeah, well, the complications, they're not inevitable. One of the question, for sure.
Yeah.
You don't just sit at home and wait for they to show up. I always talk about the diabetes warranty program. Get your eyes checked once a year by someone that really knows about diabetic eyes. Your kidney checked once a year. Examine your feet, and you'll know if you develop numbness and things like that. So being the first to know about it, and as Schafer said, even if you have a little bit, you can nip things in the bud. Yeah. You don't, to prevent them from going to late stage complications. So it's all about the duration and severity of hyperglycemia, at least with the eye, kidney, and nerves. And it's never too late to take control of your diabetes. It really isn't.
I want to kind of piggyback on this, because there's a lot of chat about statins, which is a cholesterol medication. And I think, maybe honing in on the heart disease aspect a little bit more. And this is really, what I'll say about statins is it's confusing for us doctors, because back in the day, they used to give us cholesterol cutoff levels, and they would say, if your levels were, high enough, then you get a statin. And if your levels are low enough, you don't. And nowadays, for most people with diabetes, a statin's recommended, no matter what your cholesterol levels are. And that's very confusing. Can you guys comment on that? And then, maybe, how it impacts heart disease?
Well, I'll start with the bad news. So the bad news, and kind of why we talk about heart disease all the time, is that unfortunately, just having diabetes, just having the diagnosis, regardless of your blood sugar control or whatever, increases your risk of having heart disease significantly. Even if your blood sugar is great, you've had an A1C of 7% your whole life, you're still basically double the risk of someone who doesn't have diabetes. And there's, this is an area of research that Jeremy and I work on, and so we're very interested in this and trying to figure out ways to address this. But it's a confusing topic, and it's not totally clear why. There's a lot of different factors. That being said, again, there are ways to improve your heart health and prevent those problems from happening. So focusing just on your blood sugar control, you're going to miss out on a lot of ways to help your heart stay healthy. So we always take a lot of time to talk about things like cholesterol and high blood pressure. Jeremy?
Yeah, I always tell people that, we pour over blood sugars, like the whole visit I have with somebody, talking about, pre-bolusing and things like that. And it happens a lot of times that we forget to talk about blood pressure and cholesterol, which are the most important thing for your heart and frankly, much easier to treat. Imagine you could take a pill once a day and your blood sugars would be fine all the time. That's what you can do with your cholesterol and blood pressure. And statins are very effective. They've been really vilified for unclear reasons, to be honest. But a lot of people do have issues with them. They can get muscle aches or whatever. But in the last 3 or 4 years now, there's multiple other options for bringing your cholesterol down. So please be aggressive about it. I always say that, or in general, if you're over 40 or so, that you should be on one of these medications, regardless of your blood pressure.
That's what the American Diabetes Association says, and so.
Yeah, there is a lot of bad press about statins, like Jeremy said, and some of it is sort of like that fake news stuff, but some of it, there are some medications have side effects, and that's true. But if what we also know about statins is that they significantly reduce the risk of heart attacks. So they don't cause diabetes, they don't cause dementia. We know that those are these theories that have floated around and have been disproven. There are some real side effects like muscle aches and things like that. But if you take a statin and you don't have any side effects, you are 100% reducing the risk of a heart attack. And so for us, that's so important that benefit outweighs the potential risk in most cases.
Statins are probably one of the most impressive drugs we've ever developed in the history of medicine, after insulin, of course. I mean, and the data shows that if you're someone with diabetes, you benefit more than someone without diabetes. True. And so you should do everything you can to make sure that if you get a side effect from statin, that it's really due to that. Yeah. The other thing is we got Zetia, a new one called Nexletol. Jeremy and I are on these PCSK9 inhibitors. There's Proluent, there's Repatha, and you inject it every 2 weeks. It's one of these monoclonal antibodies, and they are killer drugs. I mean, they don't kill you, but they lower your LDL like crazy, and you might need that with your statin. So it's not something.
Or if you can't tolerate a statin, those are really good options.
Yeah. So and Jeremy's right. That's the most common why us type 1s pass away. It's not from eye disease or kidney disease, heart disease, just like type 2s that have snuck onto this show.
So I would say when you see your provider, obviously you're going to have your laundry list of diabetes related things, blood sugars. Make sure you at least address blood pressure, cholesterol. And it might take 2 seconds. Your blood pressure is fine. You're on these medications. Yeah. Cholesterol's fine. Your eyes, your kind of diabetes warranty program. Yeah. You want to make sure to at least kind of touch on those things because they're easy to treat.
Yeah, very easy.
Yeah.
Okay, we only have about 3 minutes left, so I think I'm going to ask each of you just for your closing kind of summary comment or one little pearl that you want to leave everyone with. And there have been a few questions here about where we're at with the cure. So maybe, Jeremy, your little last comment could be on maybe not, comment on the cure, but also, prevention of type 1, because I think that's really a hot topic right now.
We're really on the edge of some really cool stuff with the cure. So there at the FDA now is a drug that has been shown to delay the onset of type 1 diabetes by 2 to 3 years called teplizumab. And so hopefully that'll actually get approved. And that would mean that we could identify people at risk for type 1 diabetes, give them this medication, kids, adults, whatever, delay the onset of type 1 diabetes. The first step towards getting a therapy that actually does something to the disease itself. Because we talk about blood sugars and everything, which is the outcome of losing beta cells. But what about saving our beta cells in the first place? Yeah. So having a first approved drug, I think, refocuses the attention on this whole field. What can we do to stop the autoimmune attack? What can we do, even if you are newly diagnosed with type 1 diabetes? You still have a lot of beta cells that are worth saving. There's companies working on new immunotherapies. Dompe is one of them. To help preserve whatever beta cells you have when you're first diagnosed. So I would say in the next year or two, we'll probably have a medication to start to help prevent type 1 diabetes, maybe some therapies to help preserve insulin when you're diagnosed. You're still left with those old timers that, the damage has kind of been done and we'll need some kind of beta cell replacement. Give me back some beta cells. And Aaron Kowalski did a good job talking about what's going on in that space. So a ton of stuff. To be honest, I'm fine with like if this doesn't happen. Like I feel like these systems that we're developing are doing good by us. I'm really hopeful for these things, obviously.
Yeah.
But I'm not sitting here waiting, like pining. When am I gonna be done with this?
And these things always take a little bit longer than we want them to.
Yeah, for sure.
We say hopefully
Yeah.
the next couple of years, not maybe.
So like I said, who was told when they were diagnosed that we'd have a cure in 10 to 15 years?
yeah.
Everybody was said this. It's right around the corner. That corner is just really long, I guess. So like it's like really far away.
So don't wait for it, and don't wait for the next pump or whatever.
Yeah.
I mean,
Yeah.
go
Take
do it
control.
now. Yeah, take
Yeah.
control today.
Any closing comments, Schafer?
Yeah, I guess I was just gonna say, since Bill Polanski's not here, maybe I'll do something little touchy feely. I think you guys left him on the side of the road somewhere.
Yeah.
He's out there. He's hitchhiking home.
Under the freeway.
Yeah. Well, my takeaway would be, this has been, first of all, it's been an awesome conference, and we miss seeing everybody in person, but we were able to get a lot of people here that wouldn't have been able to be here in person, and that's what I love about this. So thank you for being here. I hope you guys learned a lot. I learned a lot, and my advice is, if you haven't done this, take a moment during one of these breaks and consciously just think about, one or two things that you learned, or one or two things that you want to take away from today that you're going to actually do, or that you're going to talk to your provider about. Because we talk about so much stuff, but just make sure you find something actionable that you're going to kind of move forward with and improve your life and help yourself take control of your diabetes.
You're getting closer to that award, buddy.
Oh, yeah.
You really are.
He's really trying, but I don't know.
Well, there's
next year.
really 2 seconds left, but I would just like to say that the purpose of the organization, and Jeremy said it quite right, is to really help you take care of your diabetes so that when that cure comes along, you'll be a healthy enough recipient to receive that cure.
Well, you want to close?
Yeah, thanks so much for coming, everybody. We really love seeing you all here, and it's been such a great, positive day, and thanks so much, guys.
Yeah.
Trish. Yeah,
All
thank
right,
you all.
back to the conference. Back to the bus, I guess.
Yeah, the bus.
Okay. Bye, guys.
Bye.